Good afternoon, everyone, and thank you for joining. We're going to let everyone continue to log on and get started in just a couple of minutes. All right, let's go ahead and get started. Hi, everyone. Thank you for joining today's webinar, The No Surprises Act, What We Know So Far. Today's program will be presented by Dominic Segala, Principal and Market Leader, and Kathy Ruggieri, Principal of Withum's Healthcare Advisory Team. Before we begin, I have a few notes. Today's materials can be found in the toolbar on the right of your screen. Also, at the bottom of the toolbar, you will see a questions box. Feel free to send us your questions during the presentation. We'll do our best to address them at the end. There will be 4 polling questions throughout the program. To qualify for CPE credit, you must participate in each poll. CPE certificates will be emailed to you within a few weeks. And finally, once the webinar is over, there will be a pop-up asking you to complete a survey of today's webinar. Please take a moment to complete it. It is our way of being able to provide you with the best and most relevant programs possible. With that, I'll turn it over to Dominic.
Thank you, Rachel, and good afternoon, everyone, and thank you for joining us on the discussion around the No Surprises Act. I think it's the hottest topic right now in healthcare. Everyone is aware that probably over the past 2 years, Congress has been working on this, and it became effective 1/1/22. And it's really to protect the consumer for those out-of-network payments or out-of-network bills that you receive. A lot of information. There's a lot of information we don't know yet. But we're going to do our best over the next hour really to hit on all the major topics of this and give you some insight into what we're seeing at some of our clients. But before we get to that, I just wanted to offer up one other thing also. In terms of many of you on the call received provider relief funds, if you receive these funds between July 1st of 2020 and December 31st, you're now in the period 2 reporting period. So the portal's open now for period 2 until March 31st. And many of you hopefully receive phase 4 funds. And just a little update on that, you have until 12/31/22 to utilize those funds, and it goes retro to 1/1/20. So it's a full 3 years you have to utilize those funds, again, lost revenue and the incremental expenses. So just wanted to make sure everyone was aware of that because that is important. But back to, before I turn it over to Kathy on the No Surprises Act, I found a few stats that I thought were really interesting, and it sort of tees up how important this is and what a big issue and why Congress has moved on it. So 1 in 5 ED visits, the consumers inadvertently receive care from an out-of-network provider. So 20% of those ED visits, that patient is not even aware that they've received care from an out-of-network provider, which could be a substantial bill. And the other one I found interesting was between 9 and 15% of in-network hospitalizations for non-emergent care, so you didn't go through the emergency room, you ended up with a hospitalization, include surprise bill from an out-of-network provider, such as anesthesia, whom the patient did not choose. So clearly, this is a big issue. We're going to talk about it. We're going to give you some very relevant detail of what we're seeing at our clients. And again, there's a lot of questions. We'll try to get to them at the end. If we don't, we will follow up with emails. Before I turn it over to Kathy, we're going to start off with our first polling question.
Our first polling question. Do you understand the No Surprises Act to include the good faith estimate requirements? Completely, somewhat, or not at all? And apologies for the typo. All right, 15 more seconds. All right, 10 seconds and I'll close it out. All right, and here are the results. Looks like 64% voted somewhat.
Okay, hi everyone. So I thought that I would start off, Dominic gave some statistics. I thought I'd start out with just an example that I had encountered a couple of years ago. I was helping a family friend deal with some medical bill issues, and she had gone to a very prominent New York City hospital to have a baby. And she had done all her research. Her obstetrician was in network, the hospital was in network, the pediatrician was in network. But what had happened was something unexpected, and she went into labor 4 weeks early. So she had the baby, everything was fine, but they did need to receive services by the neonatologist. And receive NICU services at the hospital. The neonatologist was not in network, even though it was the premier group that provided neonatology services to all of their patients. They were not in network. So she received a $200,000 bill. And this is an example of why the federal government has taken such an interest in this, because this is one example of millions in terms of the impact to patients. So they really so I just thought I would give that and start that as an out of network example. So we're going to today, as Dominic mentioned, we're going to discuss the new federal No Surprises Act. This legislation was included as part of the Consolidated Appropriations Act that was passed by Congress in December 2020. The new regulations became effective just this past January 1st, 2022. The details concerning the new regulations were more recently published as interim final rules. So it took kind of a while for all of the behind the scenes to really publish in terms of how this was all going to work. So about 6 months later, CMS and the federal and other federal agencies published the first interim final rule, and then a second one on September 30th of 2021. Both of them allowed for comment periods, which have since passed. And then, like I mentioned, the new regulations just became effective on January 1st, 2022. So the No Surprises Act really includes two sets of rules that providers will need to comply with. The first one pertains to the surprise billing, where typically the scenario is a patient, as I noted in the first example, a patient receives a bill after receiving services from an out-of-network provider through no fault of their own. They weren't able to choose. And they ended up receiving a much higher bill than expected. So that is really the definition that CMS will provide in terms of surprise billing. These regulations will replace surprise billing, meaning getting this out-of-network bill, with the new payment methodology that we'll talk about today. And then the second set of rules that are part of the No Surprises Act involve the provision of good faith estimates of charges for self-pay patients. It's important to keep these requirements separate. The provider who is subject to these rules will vary across the two of them. And the good faith estimate we feel is broader and probably a little bit more impactful for physician practices immediately, more so than the No Surprises Act. This slide here, I'm just going to kind of walk through kind of the details of we provided a lot of links in terms of all of the regulations that are out there in terms of the interim final rules that I mentioned and the Consolidated Appropriations Act and all of that. So all of those links are part of our presentation. But we're going to start with the surprise billing rules. So these new rules apply to healthcare entities. Okay, so it would include facilities such as hospitals, critical access hospitals as well, freestanding emergency departments, ambulatory surgery centers. Urgent care centers are not included in facilities that pertaining to this rule. The rule also applies to providers that furnish services to patients in facilities. These rules do not apply to physicians not providing services at facilities. So if you have your physician practice and you're providing services to patients that have that you're not participating with, they're out of network, but you're providing the services in the doctor's office, these do not pertain to that. So essentially, we are referring to hospital-based physicians such as anesthesiologists, radiologists, hospitalists, as well as physicians who provide services directly to their own patients in the hospital, and then physicians who provide on-call services in the hospital. In addition to healthcare entities, these rules also apply to healthcare plans. Okay, and it is broad, but it includes like group coverage, both the ERISA regulated self-funded plans, as well as state regulated fully insured products. Individual coverage plans, both exchange and non-exchange plans, including student health insurance coverage. Not subject to these rules are plans, Medicare Advantage plans, managed Medicaid plans. They're already subject to their own requirements and they're not part of this regulation. Also, limited benefit plans such as health reimbursement arrangements and also health sharing ministries, which is definitely something I've seen a lot more of in the last several years. They are not subject to the No Surprises Act. So, so this is federal legislation, but it specifically provides that if a state has an established legislative requirements to address surprise billing, which many states do. Actually, I think it's like 30 some odd states that do have some level of state requirements that are all different. The federal law states that the requirements should be read consistent with the state requirements. So as you consider your compliance with these rules, you wanted to review the specific state rules to determine how they match up to meet the requirements for both. It also is important to note that the self-funded plans are not subject to the state laws. So, and it would only include fully insured products that would fall under the state law. So that's really, really important. I know in New Jersey and New York, those states have surprise billing laws, but these self-funded plans are not subject to the state laws. Did you want to add
So,
something, Dominic?
yeah, so this is a lot of good information, Kathy. How do these regulations apply specifically for emergency and non-emergency services?
Okay, so in the case of emergency services, whether it's an in-network or out-of-network facility, the rules will apply. It's an emergency. What happens in the case of an emergency, the facility and the providers at the facility are subject from are prohibited from billing the patient as out-of-network. Also, with that, emergency services includes, necessary post-stabilization services. So this could potentially include the inpatient admission and outpatient observation services as well, as determined by the treating physician. So that's really the important point here. They're really looking to apply prudent layperson standards to determine what constitutes an emergency. And then the insurance plans can't require any prior authorizations nor limit coverage for emergency services as well. So that definitely is an added bonus and can be some, can pose some problems historically for providers. There are some opportunities, I think, this area in terms of patients who require, services, inpatient services. There may be some opportunities for once the patient is stabilized in terms of a waiver, but those are just things that really probably should be discussed with your legal departments, just to make sure that you're handling those situations properly. In the case of non-emergency services, the law does not apply to non-emergency services at an out-of-network facility. So if a facility is not participating with an insurance and it's not an emergency service, they're coming there for something else, all of these regulations would not apply if the hospital itself was not participating. However, this No Surprises Act does apply when the following services are furnished by an out-of-network provider at an in-network facility. So providers of care who are out-of-network providing services as an in-network facility are prohibited from balance billing the patient in any scenario. They can't obtain any waiver to balance bill the patient. These would include anesthesiologists, pathologists, radiologists, neonatologists, also, assistant surgeons, hospitalists, intensivists, doctors that typically patients don't see, that are behind the scenes. They don't have direct patient contact. Does not apply to out-of-network physicians who are front-facing physicians. They can balance bill a patient only if an advance notice and a written consent is obtained from the patient. So this would be like a surgical patient who sees the physician in their office. They make arrangements for the surgery, they book the surgery at an in-network facility. The patient is out of network. If you're looking to bill the patient as out of network and have them be responsible, then there's the waivers and all of those things that we're going to get to. So I think that's the real distinction there.
Thanks, Kathy.
Sure. So I think we can move now to the next slide. Rach. So in terms of advance notice and consents, there is a standard notice of a consent to obtain from a patient to be balance billed as out of network. And we provide, we provide a link for the notices on this slide here. The standard notice should be posted in your facility. In terms of timing, if the service is scheduled at least 72, the service should be scheduled at least 72 hours in advance. In situations where it's not, then the notice must be provided on the day of appointment, but no less than 3 hours before obtaining service. So, sometimes there's like urgent things that can occur, and they've tried to account for that in terms of the timing with the regulations. We also, there was some mention in the rule that that in the event you are getting consents from patients to accept responsibility for out of network, there also is something that says that it will have to be provided to the actual insurance plan. However, that is not, I have not seen anything recently on that in terms of how that is defined and how that's going to occur. Because you think, a lot of this billing is electronic, and will it be an attachment, or that has not been worked out. I have not seen anything on that recently, but we will continue to monitor the regulations for new information. So we're going to move forward to the next slide.
Kathy, I have a question for you on this slide. So if we can't balance bill the patient because of the surprise billing rules apply, how will the provider be paid for the services furnished?
Okay, so good question. The bottom line is how will we be reimbursed? So first, I think we're just going to start off with how much the patient can be charged. So the provider cannot charge the patient more than the patient would have been charged had they received services in an in-network facility. Okay, that sounds great, but how do they, they don't have that information. So since a provider is out of network, they don't have a negotiated contract rate with the out of network plan. So you don't know what the patient would be charged. So to solve this issue of determining the contract rate, the whole concept of the qualifying payment amount, which is the QPA, has been developed by CMS. So the qualifying payment amount is essentially the insurance plan's 2019 median in-network rate paid for the same or similar service in the geographic area. So that's kind of crazy because that is really broad. But they're going to start with 2019, and then there's rules where the rates are going to be indexed for subsequent years. So the qualifying payment amount is the median as of 1/31/2019. And then just this past December, the IRS posted a notice that the CPI-U adjustment rate is going to be 1.065%, will be the first index. So,
and Kathy, I just wanted to interject. So, I mean, clearly there's a lot of contention around this, right? I mean, it's clear as mud. No one knows, no one's defined what this median in-network rate is. Each payer would come up with something different. Have we seen any clarification on this? I mean, I believe this is what's caused most of the lawsuits from the physician groups against this ruling, because it seems like the payer just has the advantage of defining what this median in-network rate is.
So what we've really started to see, and the first webinar that we did, we definitely got some feedback on this as well, is that providers are starting to see their payers are now kind of ending their agreements. So because I think they're banking on the fact that their contracted rates could potentially be higher than the 2019 median. So it's really disconcerting. I mean, it's it's a major issue. There's all of these lawsuits, the AMA, one for sure, and there's just a lot of things going on. So I think we're going to continue to hear a lot about this. I don't think that this was the intention at all by CMS, but this was kind of the result that in terms of what has actually happened. The other thing is going back to the 2019 median. There is nowhere to go for these rates. They're not posted. They're not available. There's nowhere where we can, but we really have any idea what these median rates are for any geographic location by procedure. So there are still, unfortunately, Dominic, a lot of unknowns.
And clearly, this is where potentially could be a significant financial hit to some of these providers who fall into this bucket, and defining what this median rate could be if it's less than what they're normally being reimbursed.
Yeah, I think that if especially in the example that I just gave, where somebody was in network and their contract was terminated, and now they're, now they're subject to the median and their rates were really good, that definitely is going to be a major financial impact. Right. So because this is a median, like I just said, they're going to be calculating the payer is going to be calculating the qualifying payment amount. So there's not going to be a rate schedule for this specific patient to refer to, like I mentioned. So essentially, what's going to happen is the provider will submit the bill to the plan. They determine that it's an out-of-network service, and they will determine what the qualifying payment amount is. So once the plan processes the claim and determines that the patient has, say, a 20% coinsurance, and the qualifying payment amount is $1,000, then that's where we can determine the patient responsibility is $200. So it's really at this point in time where you determine the QPA is really where you know what the patient responsibility is. I mean, you do see if you're doing insurance eligibility and you're running those things in advance, you do know that you do know what the patient responsibility percentages are, but you don't know what the QPA is. So it's very, very difficult to determine what the actual patient responsibility amount is. So in that example that I just gave, under the surprise billing rules, you would be able to bill the patient $200. So I think we're going to move to polling question number 2.
Our second polling question. Are you aware of the timelines associated with the various appeals process? Somewhat, completely, somewhat, or not at all? For about 20 more seconds. All right, 10 more seconds and I'll close it out. Okay, and here are the results. Looks like 56% voted somewhat.
Okay, 56% somewhat, and I think like 38% not at all. So
Makes sense.
okay. So so now we're going to talk about how the provider is paid by the out-of-network plan. So I just kind of talked a little bit about how the qualifying payment amount is determined. So what I thought I would do was kind of walk us through kind of like a life of a claim and the appeals process that is available to providers. So so I think I mentioned that at the end of 2020, these regs became aware that this was going to be coming down the pike in 2022, but it took like 9 months for CMS to actually tell us how providers would be paid. And they did that in the September 30th, the second interim final rule on September 30th, they kind of laid out the plan for payment for out of network. So the provider will submit a clean claim to the plan. And that's kind of when everything kind of starts. The payer sends the provider, they have 30 days. Once they have all of the claim is clean and they have the appropriate supporting documentation and information to pay, they send the provider initial payment. And like I said before, that's called the qualifying payment amount. And this would occur after all the relevant data is received. The provider, if they are not satisfied with the payment that is initiated by the plan, they have 30 days to open a negotiation period. And that starts with that initial payment or denial that the provider receives. So this is really the opportunity where the providers can go back and forth with the plans to try to negotiate a higher rate. If the provider is not satisfied and they feel that they want to move this forward, either party, and in all cases, it's going to be the provider, they can initiate an independent dispute resolution, which industry is calling the IDR, following a failed open negotiation with the payer. And this process is actually going to be a federal portal is going to be created where the providers would actually initiate the independent resolution. And so that has to be within 4 days of when the open negotiation period ends. So like I said, you have the 30 days to negotiate with the plan. And at that point, after the 30 days, you have four business days to initiate the independent resolution.
And Kathy, just a quick comment. I assume for a small volume provider, this won't be as difficult, but when you start getting numerous amounts of denials, are you seeing out of your clients the need for a workflow tool to be in place to track this, to know the dates and the times? Because it seems like it's going to be very cumbersome.
Yeah, we're going to get to that a little bit further, but yes, as we talk through, 30 days for this and 4 days for this and 6 days for this and 8 days for that. I mean, it's like, oh my goodness, like how, you have one claim, that's one thing, but if you have hundreds or thousands of claims that fall into this process, then it's really going to be important to have tools to be able to effectively manage. So definitely, okay. And like I said, we'll get to a little bit more detailed about that soon. I think we can go to the next slide, Rachel. So after the initiation by the provider of the independent dispute resolution, the parties have the opportunity to mutually agree on the IDR entity selection. So there will be a third party involved in terms of who is going to be involved in reviewing this. Each the provider and the payer, there's a $50 administrative fee that is due within 3 business days after the IDR initiation date. So if they can't agree, the agency departments will select an IDR entity within 6 business days. And then after that, within 10 days, this is where the provider has the opportunity. The parties submit payment offers and any additional information to the IDR entity. So this is really the opportunity for the provider to kind of state their final case in terms of why they feel that additional reimbursement is justified. We're going to get to that a little bit further as well.
Okay, I'll hold off on my question.
Okay, and then the payment determination is then made by the IDR, and this is really kind of like, it's like they either are going to side with the provider or they're going to side with the payer. It's not going to be like something in the middle. It's going to be, they're going to agree with one or the other. There is no negotiating at that point, and the IDR entity will make that determination. This process is really, we can't really elaborate it on that much because we don't really have a lot more detail than what we're outlining today. We do know, though, that whoever loses, if they say they side with the provider, that the provider is due more revenue, and the payer loses, the payer is then responsible for the fees to actually initiate the dispute. And we're expecting that the fees are going to average like somewhere between $200 to $500. And that's going to be like a 30-day process for this part of the review. So I think it's important that providers are going to have to be really specific. Like if you just have a $100 bill and you got something that was less than what you had before, this process is not. I mean, this is a costly process. So this is going to be for your much larger providers, like the ones we talked about earlier. Your specialists, your surgeons, neonatologists, hospitalists, etc., where there could be thousands of dollars of difference. And then the payment is submitted to the applicable party within 30 days after the payment determination is made. So you can see that this is a lengthy process. It requires a lot of coordination and tracking and so forth. So next slide. So the independent dispute resolution, the IDR, will be operating with the qualifying payment amount as the appropriate rate. Okay, like we said, this was the median. They went back the geographic area. So since the QPA is a median, half of providers receive more, half providers receive less. So providers will be negotiating for a median. The IDR can take in consideration other relative factors. So if you really feel as a provider that you're due additional revenue, your appeal and the documentation that we talked about earlier in terms of when you actually state your case, that's where you really justify, like the training and the expertise of the physicians, the patient's acuity, any complexities, all of that would need to be included in the briefing that the provider prepares when negotiating.
And that's what I was money. Right, and that's what I was going to ask you before, and you answered that. During that negotiation, it's not about, I need this because of additional cost. It's more clearly about the clinical care that was provided and the costs that are associated with that.
Yeah, and they really are frowning upon like usual and customary terminology, and 2 times, 3 times, whatever it is, the Medicare rate. Like that's not going to advance you in the process. It's really about a clinical appeal with things that I just talked about, the training, the expertise of the physician, the complexities of the patient, that would justify more revenue. That is what is going to win these appeals. So, so it's January 19th, and there's still a lot of unknowns. This whole negotiation process and period and the parties that are going to be involved is still being worked out. Those details have not been provided yet, as I know. So by Q2, we should really understand a lot more about this, about what to expect, especially with this negotiation process. And hopefully some of this information we'll be receiving soon. One thing that is a positive, that the out-of-network payments must be issued to the providers and not the patients per the new law. So that definitely is a plus. But nothing, like we talked about earlier, in terms of that at some point there is going to have to be probably like a data element on the claim or something, that the consent was signed or some attachment. But like I indicated earlier, that process has not been ironed out yet. So that is definitely an open item. So I think the most important thing, and Dominic referenced it before, a question to me was the workflow. So this is just when you hear us talk about all of these new requirements, and if you do decide to engage in going through this process, where more money, there's a justification for more revenue, you're really going to need to have a process to really track and be able to keep track of these accounts and be able to meet these deadlines. So if you have an existing workflow system or some other tools to be able to, ticklers or so forth. I mean, if you're a smaller practice, you might be able to get away with a more manual tickler process. But if you're going to have any type of volume, you're going to really need to give considerable thought to the workflow process.
So Kathy, I have a question for you. So I do a lot of work for a large neurosurgery practice in New York, mostly out of network currently. So New York has existing state laws, and they call it the Fair Health Rate Structure for fully funded plans. But I was wondering, how will existing state laws work moving forward in 2022 as it pertains to payment? And I know you touched on it a little bit, but maybe you could expand on that for me.
Yeah, well, I think, I don't have that much more information, but existing state law will continue to apply to those plans which it previously applied, both with regard to the amount of the patient's responsibility and the payment by the plan to the out-of-network provider. But like I said, where things get tricky is when the plans are subject to state laws, such as the ERISA regulated plans. Those are where the No Surprises Act will apply. So the state laws will not be part of these self-funded plans. And so I think that this QPA process that we just outlined and talked about, that's where it's really going to apply with these ERISA plans. So, making sure that you have ways to be able to flag and identify these accounts, that and be able to stay true to the timelines is really going to be probably one of the more challenging things.
Thanks.
Next slide. And actually, I think I covered this one already, Rachel. Next one. So notice requirements. So there are some additional notice requirements. Facilities and providers who furnish services in facilities must provide notice to patients of the No Surprises Act protections. And this can be accomplished 3 ways: to actually post at the physical location. And I think everyone is kind of moving forward with posting with the HIPAA notice of privacy. So just have them be in the same areas where you have the HIPAA notices today. Posting something on the website with the link to the NSA protections, and just link that from your homepage. And then, or lastly, giving it to the patient. So it wouldn't be Medicare or Medicaid. It can be delivered via paper or electronically, to avoid a lot of paper. You can make arrangements with facilities to limit your notice. So if you're an anesthesiology group, you can make arrangements with the hospital where they have to provide the notices already, even if they're in network. You know, like I said, it's only care or K that doesn't require the notice. So you can just have like a quick little agreement with the hospital, and then their notice would satisfy as your notice. So all of those, you know, ancillary physicians like anesthesiologists, radiologists, et cetera, can just work with the hospital providers on that.
So that wraps up the No Surprises Act. And the next 10 minutes or so here, Kathy's going to go over the good faith estimate of charge requirements, which really is a second piece of this.
Yeah, I'm going to move through this quickly. There's details, but not quite as elaborate with the whole appeals process that we went through for the No Surprises Act. So the good faith estimate for self-patients. So we started with in terms of facility for out-of-network and in-network with regard to the No Surprises Act. And good faith estimates requirements, however, are applicable for everyone. So there's not that distinction between in-network or out-of-network. And it does apply to physicians in their offices. So this is a little bit different than what we just went through for the No Surprises Act. Surprise billing. So this does apply to physician practices. So this includes all services, office visits, diagnostic testing, and surgeries. And this requirement is that a good faith estimate is provided in two scenarios. When a self-pay patient could be doing some comparison shopping, or upon scheduling a self-pay patient, you know, just providing the patient with an estimate as long as the visit is scheduled 3 days in advance. The estimate really needs to also include a lot of people offer self-pay discounts for the self-pay population. So any self-pay discount would need to be included in the good faith estimate. So let's define what self-pay means. So self-pay means patients that don't have insurance, patients who have insurance, but they don't want their insurance to be billed. They have insurance, but that item or service is not covered. Or they have insurance, but no coverage for out-of-network services. So that would be the definition of a self-pay patient. So the good faith estimate notice requirements communicate to all self-pay patients that are entitled to a good faith estimate when they're scheduling. Post the good faith estimate notice on your website. Post at your physical locations. This would now be physician practices and offices and et cetera, all locations. And we did, I think the next slide, Rachel, we did provide the actual notice link on the last bullet here, the actual good faith estimate notice, and there's an example on the website. So when you open up this link, you're going to get a whole like zip file of files, and the first three in the listing are all related to the notice requirements.
And Kathy, do you think the good faith estimate for self-pay patients is that big of a change for many of the providers out there?
I think a lot of providers had a lot of this in place already. So I think that some people are doing it. And then I know like with some of my existing clients, they were doing a lot of this already. But I do think that, you know, not everyone will have all of this in place. So it's just going to really, the individual practices and providers are really going to have to really take a close look to just make sure that, you know, if you have a self-pay patient, you're able to provide them with an estimate in advance, and that you're in compliance with, you know, this part of the new regulation. There is a little bit of a dispute resolution process. Next slide, Rachel. Self-pay patients can initiate a formal dispute when they're billed $400 more than the amount that's listed on the good faith estimate. So if I estimate that your responsibility is $1,000 or $100, and I bill you $1,000, it's $400 or greater than the estimate, and then you have an opportunity to dispute it. The patient must initiate a dispute within 120 days of receiving the bill. The CMS will identify a dispute resolution entity. So another department is coming down the pike, similar to what we talked about earlier with the no surprises. The provider has 10 days to respond with credible information to support the higher charges. So I think this is where, like, price estimation software and tools and things that you're using to be able to give a good faith estimate, making sure you have online access to that information. You could be providing that in your actual dispute process when you're actually going through this process. If a patient is disputing it, you have the backup to support why you made the estimate that you made. So if there's no credible information found by this new dispute resolution entity, then the provider is bound by the good faith estimate. So whatever estimate they did provide would hold true, and that would be what the patient would be responsible for. So very, very important to really make sure that you have the audit trail of the documents.
So Kathy, before we go to polling question 3, and I know time is coming short here, what can providers do to make sure, they're in compliance with now that this is, in front of us, and now that it's a part of all the providers that are out there?
Right, so when we did this in December, it was, I think, 15 days to counting in terms of the regulations, but now we're already 19 days into January. So I think the first off is just making sure that you're in compliance with the notice requirements. Obtain written agreement with the facilities. So if you are an ancillary provider and working with, and you're providing services at the hospital, having that agreement with the hospital. Those are easy things to kind of put into place. I think where, we talked about touch on a little bit is being able to really develop your operational processes to identify the services that are subject to the surprise billing, that specifically the out-of-network emergency services and the out-of-network non-emergency services that are furnished at an in-network facility. So you want to be able to have a way to really identify those patients. So, if you have workflow tools, I know with some of my clients, being able to really spool these accounts to a workflow list, and we haven't gotten any payments yet, but I'm expecting, like, in the next few weeks, we're really going to start to see some payments on some of these early 2022 accounts. So you want to be able to jump on really looking at what's being paid and really understanding what the changes are and what the implications are. So I think that is really, really essential. We're setting up huddles to be able to just kind of, like I said, we're routing these accounts to work lists and then looking at them so we can really speak to the impact to the practice. Now we're kind of, this is really more for December, but it does kind of apply now if you have patients for, the rest of this month and next month, really, that are already scheduled. You want to just kind of take a look at them just to see the out-of-network responsibility, out-of-network patients that are already scheduled, and just make sure if there's any interactions that need to happen with the patient, you're acting on that now before the patient has it. And this really would be more applicable to, surgical patients and that sort of thing. And then lastly, I think what's really, really important is the educating of your physicians and the operational team and that coordination. I think that there are a lot of unknowns in terms of the actual revenue for the out-of-network providers. So, you don't, this is going to be this first quarter and second quarter is just going to be really important that there's open dialogue with the physicians, because this is definitely something that is hitting them very hard financially or potentially could be. So it's just important to have that communication.
I think it's the next polling question.
We're on to our third polling question. Do you understand the financial impact this could have on your reimbursement? All right, 20 more seconds.
Okay.
All right, and here are the results real quick. 63% voted somewhat.
Yeah, so similar to the other questions. So I think
Right.
we're just going to, so I think like we talked about, there are a lot of unknowns, so we expected to see mostly, actually there were some completelys on that one. There was like 20%, but we do expect that because there are unknowns that we just don't know the financial implications, but we're going to keep really close tabs on these issues and try to circulate more information in the coming weeks and months with pertaining to what we really see as claims start to get processed. And we do have the requirements for the good faith estimate. I'm not really going to go too much. It's really kind of hand in hand with the surprise billing. Do you want to just lob us out a question or two, Rachel? No, are there any questions?
Sure, yeah, there are a couple questions, and I do want to make sure that we get our fourth polling question if we want to do that first.
Oh, the fourth polling question is fun.
All right, so we'll do that, and then we'll go to some audience questions.
Okay, sure.
All right, our fourth and final polling question. Is it going to snow this weekend?
Okay.
Reminder, get your votes in just before we close it out to get CPE credit. About 10 more seconds. All right, I'm gonna go ahead and close it out. And here are the results just for fun. So it looks like all right. So now on to some audience questions, and we'll try to get through some. We want to be mindful of everyone's time. If we don't get to your question, Dominic and Kathy will reach out to you afterwards. The first question, what about Medicare wraparound plans? This was earlier in the presentation.
Yeah, so Medicare and Medicare managed care plans are not subject to this. Like I said, I think, and Medicaid managed care are not subject to these plans or to these rules. These are really, all the other insurance plans outside of that. And I kind of specified, those earlier in the presentation, but no to that.
Next one is to clarify, OON ASCs are not subject to this rule. Physicians treating are also OON and are not subject as well.
Can you read that one more time?
Yes. To clarify, OON ASCs are not subject to this rule. Physicians treating are also OON and are not subject to this as well. And that's a question.
So the ambulatory surgery centers are an entity that is part of the surprise billing. So yes, in terms of out of network, that would apply to surgery centers.
Correct. They're part of the covered health facility.
And we can circle back with that. We can circle back with the provider that asked that question just to make sure that we have all the details correct.
The next one, will the 990 include questions related to the surprise billing practices?
I'm going to give that one to Dom.
That's a great question, and more to come on that, but really good question. I'll have to reach out to our not-for-profit group and understand more on that.
Our next one, can you list the payers again that are excluded? I hear managed Medicaid and Medicare Advantage. Are those the only payers?
So yeah, as Kathy said, it's the Medicares, any type of Medicare plan, and the Medicaid and any type of Medicaid alternate plan like a Medicaid Advantage are excluded. All other commercials are included.
So group coverage plans, both ERISA regulated self-funded plans as well as state regulated fully insured products, individual coverage plans, both exchange and non-exchange plans, including student health insurance, not subject, or exactly the Medicare Advantage and the managed Medicaid plans, and then the health sharing ministries are not subject to surprise billing at all as well.
Okay, thank you. This is the last question. How do you measure 30 days if some insurers keep asking and prolonging information requested?
So I think, first of all, that's a really good question. But I think the way that it's termed in the rules is that once they have all the information, so if they're missing the authorization or they're missing a report or something like that, it's when they have all the information that 30-day clock starts. So I think that that's kind of, we talked about the submission of the clean claim, but also any supporting documents as well for them to process the claim appropriately. It falls into that category.
Great, thank you so much. That was our last question. Thank you everyone for joining. A recording and today's materials will be circulated either at the end of this week or next week.
Thank you, everybody, and reach out if you have any questions. Have a great day.
Feel free to reach out. Thank you.